About family medicine and continuity of care and evidence for it. And I'll ask you to kind of switch your brain a little bit because we went from like subspecialty advanced pancreatic cancer treatment to some advanced imaging. But if you were here last night, I want you to go back to that place where we had some of that preliminary data from the STEP survey. It was quite alarming. I'll mention some of the highlights. And it's just fortuitous that that came last night before my presentation today, because there is evidence for continuity of care and high-quality family medicine, primary prevention. I'd heard there were some issues with patient attachment, and I'll introduce myself in a little more detail in a second. But in Cayman, that could be an issue, that screening maybe was not robust or systematic. So I put this talk together, and I think that the data that's coming out makes this much more important right now. For individual patients, if you have pancreatic cancer, you got to get the best treatment for sure. But this is something that affects everyone. So, before I get into the slides, because I didn't have time to add it, I think it was Ms. Corbett was the epidemiologist, and she was saying that there's about 1,000 diabetics that don't know they're diabetic. There's 3,000 diabetics who are on no treatment. So that's 4,000 people. Doesn't sound like a lot, but there's only 80-something thousand people here, and that's just the diabetes. There's other silent killers. There's hypertension, dyslipidemia, cancer, and it's the diabetes that can present earlier because it's more associated with obesity, but it's going to be the cancer and cardiovascular disease that will present later with age. So, a really concerning number that she provided was that Cayman has 2.5 times the global average for amputations among diabetic men. If that's one of our leading indicators for where everything else is going to land, that's alarming, and people should be worried. I would describe it as a tsunami of pathology that's coming, probably over the next 10 to 20 years. And it's inevitable. People are the same around the world. The incidence of cancer varies slightly, but it's inevitable. I moved here from Canada in July, and my average patient in my clinic was 65. And I was diagnosing a lot of cancer, colon cancer, breast cancer. Every couple months, we'd see something, or I'd diagnose something. So family medicine, so this is me. I'm Dr. Kwinter. So my MD, that's from the University of Kentucky in the States. The CCFP, I did a family medicine residency in Canada, and the EM, I did some extra work and extra exams and got certification in emergency medicine. So for the last 8 to 10 years, whether you count residency, I've been working in a rural community, doing 8 12-hour shifts in the ER, OR assisting, running my own single physician family medicine clinic with 1,000 patients, running a retirement home, doing a procedures clinic, and saw a ton of patients. And so I will get into the presentation in a second, but I diagnosed a lot of cancer patients in clinic, and I've also diagnosed a lot in the ER. And there's a huge difference. The ones in clinic, usually, it's with screening, and they're upset, and the family's upset, but it got to do it enough that you could be somewhat reassuring. You don't give false hope, but you say in most cases, you can have one surgery, you won't need chemo, you won't need radiation, there's a good chance that there'll be a good outcome. When you're diagnosing people in the ER, you're having people with bowel obstructions, painless jaundice because they're having metastases. It's much later stage. It's a much worse outcome. Patients suffer, their families suffer. It's not something that there's usually such a good outcome. So what is family medicine? I'll go through this kind of quickly. It's a 2 to 3 year program in the US and Canada. I'm told in the UK there's a comparable training regime that basically involves going through a little bit of all the specialties. So preventative medicine being key. So that's basically your evidence-based screening. And that's following guidelines. So if you go to your doctor and ask for screening, they're not just checking every box there. You're getting things done that actually have evidence behind them. There's guidelines from all different countries. They overlap more than they disagree. Acute care is self-explanatory. So asthma, gout, COPD infections, chronic disease management, so managing things like diabetes, dyslipidemia. Minor surgical procedures, so lumps and bumps. General surgery, so we do a rotation to know what patients need surgery, what the surgery looks like. We scrub, We deal with post-op, and then we're able to identify complications. Orthopedic surgery, so we can reduce fractures, reduce shoulders, hip dislocations, patella dislocations, and also know, when a patient needs surgery and when they don't. Pediatrics, everything from delivery to well-child checks, excluding anything in the NICU or PICU or some developmental peds, those will get referred. Obstetrics and gynecology, so in residency all the way through prenatal to delivery. And then in practice, you usually refer to the obstetrician around 36 weeks. In gynecology, all the screening up until something interventional. But even some family doctors will do endometrial biopsies in their clinics. Geriatrics, so issues of polypharmacy, frailty, deprescribing, end-of-life care. Mental health, in a rural setting, we prescribed, up until a patient's on maybe 3 or 4 meds, then we would refer, or anything that was, heavier, as in, acute mania, schizophrenia, catatonia, that would get referred immediately. Emergency medicine, almost all emergency physicians in Canada are family doctors. And community and public health. Now, this is something that just the antenna went up in the back of my head when I, moved here. And so we're taught that we are, unlike pretty much all other doctors, we have a defined population that we're responsible for, usually 1,000 to 2,000 people. And we're taught, it came back to my mind, that if you notice any pattern or anything that's either endemic or infectious or systems level that's affecting them as a group, we are the only people who are in the position to sound an alarm about it. And it is our responsibility to do that. So here, with what looks like ineffective and no systemic screening, that is the clear and present danger that will result in poor outcomes if nothing changes. So that was a long list of things, I'm sure you'd agree. And it's been documented that family doctors have, along with general internal medicine, cardiologists and oncologists, the highest complexity of conditions in their practices. This is a boring slide that kind of quantifies that just by looking at the number of reasons, diagnoses, tests, medications, treatments for the encounters of physicians in that group. And then it gets even worse if you look at the time factor at the bottom there, because we do it all with not much extra time. So what do family doctors do? Well, we stay up to date with advances and evidence in multiple specialist subject areas. We diagnose undifferentiated conditions. We help patients balance their care options with their values. Case in point, not everyone wants a colonoscopy for their colon cancer screening, and it's not indicated that everyone has to go that route. You can choose stool testing, and there's good reasons to do that. We share in patients' struggles and triumphs through that longitudinal relationship, like the baton passing last night. You get to know these people, and you can get a sense of when things are changing for them, and how to help them personally. And then the last one, as I mentioned, advocating for them at all levels of the system. Just some examples about how kind of comprehensive it can be. So about 70% of Canadian healthcare is provided by family doctors. And this one study showed that in Alberta, we deal with 86% of those with hypertension, 71% of those with diabetes. So if you have diabetes, you don't need to see an internal medicine doctor or an endocrinologist unless it becomes a very complicated case. It's just a better use of resources to have a competent family doctor do it. So what is continuity of care? Having a single physician who knows you well for many years of your life, learns about you as an individual, learns about your family history, your medical history, and takes an incremental approach. That's a big thing. When you see somebody over time, you can tell if they're down and pick up on things. You can tell if they've lost weight. You can tell if they're pale. You can tell all these subtle things, and you can pick the lowest hanging fruit of their medical presentation and try to optimize that. So the benefits, well, this is the evidence-based stuff. So continuity of care with a primary care provider increases emergency department, so that's kind of counter phrase there, but ED visits decrease. So A&E visits go down when you have increased continuity. Hospital admissions decrease, hospital readmissions decrease, all-cause mortality decreases, and healthcare costs decrease. And so we'll go into some of those more. This was a huge study in the United States. Medicare patients, 1.5 million of them among 6,500 practices. The patients with the lowest continuity cost the system 14% more, or $1,000 per year. That was a 2018 paper using 2011 data. So I'm sure with inflation, it's double or more. This is an excellent study from Norway that shows as continuity or length of the relationship with the physician increases, so all the way, the green bars on the right are a more than 15-year relationship. You can see that on the left, out of hours services decrease, so that would be calling a helpline or going to an emergency department. Admissions decrease and mortality decreases in a very nice, call it dose-dependent manner. So how does it work? This is the part where this is my impression. You receive comprehensive and up-to-date screening. So this is picking up on the cancers when you can deal with them with, if it's a breast cancer, a lumpectomy and be done. Or if a colon cancer, a simple resection and be done. You want to catch things early, or diabetes, a little bit of metformin, and monitor it before there's complications. So your healthcare resources can be used efficiently. And the follow-up, so if you go to the ER, you can get follow-up so you don't go back. If your infection's 90% better, and you see your family doctor, but you're out of pills, they could probably extend your prescription and you'll have a better outcome. Same with hospital discharges. Often patients are discharged on different regimens for their blood pressure or their diabetes because they're on a hospital diet, and then they're out and now their numbers are out of whack. If they're caught by a family doctor in that window, I've seen it time and time again, you can adjust things accordingly so they don't bounce back. And specialist referrals. Patients think that, often will think that they want to see the specialist right away, but they might get treatment that's premature, or they haven't tried first or second line things yet. The incentives aren't quite right. You really ought to ask your family doctor, because they'll have seen a lot of other patients in your situation and know when the right time to seek a specialist is. So moving on to the team-based care approach. As Dr. Talanow was saying, some of the benefits there are you can see the right specialist at the right time. There's less redundancy. Often visits can be stacked together. Colleagues can chat about patients in their office and give more information than you would get from a referral note. There's usually going to be better follow-up, and it'll be more cost-effective because you're just getting the right thing, the right visit, the right time. With that, I hand it over to Dr. Boucher.
Good morning, everybody. It's nice to see you all. I'm going to spend a few minutes